Good morning, good afternoon, everyone. Colleagues, thank you so much for joining us as part of this webinar series. I'm Joanna Riha, the research lead for gender equality and intersectionality here at the United Nations University International Institute for Global Health. And it's really my pleasure to welcome you today to the first part of this two-part webinar series, which focuses on gender dimensions of workplace violence with a particular focus on the primary healthcare workforce. And this first webinar is being co-hosted with the School of Public Health at the University of Western Cape in South Africa, the World Health Organization, and the International Labour Organization. And just to remind you that it is being recorded, and as I've mentioned, live streamed on the UNU IIGH YouTube channel. And we've already, fantastically heard from a large number of you who've registered for this webinar with regards to questions and comments on the topic. So thank you so much. But do keep your questions coming in the chat as well. So over the course of the webinar, we would very much like to still hear from you, and we will be drawing on some of the questions and comments we've received already. So I think before we dive into sort of the meat of this webinar, which focuses on really exploring frameworks and policies that exist related to workplace violence in the healthcare setting, particularly with a gendered lens, I thought it's important to sort of set the stage and provide a bit of background with regards to why we're focusing on this topic today and as part of this series more broadly. So I have a few slides, and if you'll bear with me over the next few minutes, I'll sort of lay the groundwork as to why we're focusing on this issue. And hopefully you can all see the slides. And I think just to situate the current conversations that are going to be happening, with a fantastic group of panelists who I'm going to be introducing shortly, I think, it's very hard to ignore the ongoing crises that are happening, whether they're economic, whether they're social, whether they're conflict-related, climate-related, and the impact that's having broadly on health systems, but I think really importantly on the health workforce. And as we speak to and think about, gendered workplace violence in the context of the primary healthcare workforce, it's really important for us to recognize the increased stress that is placed on healthcare workers and frontline health workers who are predominantly women in this context of polycrises. So next slide, please. And the work that I'm presenting now, just to highlight, is a bit of background, as I've mentioned already, but it's drawing on a collaborative piece of work that we've been doing with the School of Public Health at the University of Western Cape, Ifakara Institute in Tanzania, but also the Institut National de Santé Publique in Burkina Faso. So I think it's important for us to start with the question, why the primary healthcare workforce? And we are focusing on a particular group within the health workforce more broadly. And I think as we focus on issues with regards to health equity, we still have shocking statistics with regards to the number of people who do not have access to essential health services. And more than half of the world's population, if you can believe it, still continues to lack access to very basic essential health services. And as we, champion and work towards universal health coverage, the Sustainable Development Goals, there's been a large body of evidence that has been generated over the years on the importance of the primary healthcare system and primary healthcare more broadly. And it's important for us to then focus in and hone in on the health workforce who supports that. And these, as I've mentioned at the start, are predominantly women in many contexts. And yet, despite their role and the central role that they play in delivering critical services to the most marginalized, female healthcare workers' lives are really impacted and inhibited in many ways by gender inequalities. And, whether this stems from being in the lowest paid jobs and there's pay disparity, or being predominantly concentrated in sections of the health workforce that are completely undervalued and under-respected, to being excluded from decision-making, tables and bodies. And I think this has a real impact on the quality of care that a lot of these health workers are able to provide, as well as directly impacting their health and well-being. And on that note, with regards to health and well-being, I think the most insidious form of harm that many health workers face is violence, and violence that they experience while on the job, while working. And while violence, victimizes both male and female health workers, there's a body of evidence that shows that the rates, the consequences, but also the underlying power dynamics that are often driving the violence are far worse for females. Next slide, please. And so to situate this conversation in some, defining what we mean by workplace violence, but also providing some statistics with regards to the prevalence, I think it's important for us to pause and sort of get on the same page with regards to what we mean when we say, workplace violence. And it really encompasses physical, sexual, verbal, and psychological forms of violence. And it's incidents where staff are either abused, threatened, or assaulted in circumstances related to their work. And this can be, commuting to and from work as well. And it can be both implicit or explicit in terms of the impact on their safety, well-being, or health. And in terms of who are the perpetrators inflicting that violence, it ranges. And again, there's a whole body of evidence that it can be community health workers, patients, visitors, co-workers, and supervisors in many instances, and others. And, with the data that are available, there are a broad range of estimates with regards to the proportion of health workers who suffer physical violence. In particular, there's a stat from WHO that's often widely quoted between 8 to 38%, while a systematic review and meta-analysis has also found that, there's often underreporting, and in some cases it's likely to be much higher. So up to almost 62% of health workers are reported to have been exposed to any form of violence. So a large number, almost half, being exposed to non-physical violence, 25%, almost being exposed to physical violence. And what this constitutes in terms of the non-physical forms, it can range from, threats to sexual harassment. And I think it's really important as we have these conversations today that we keep in mind, yes, centering the health and care workers themselves in terms of safety and well-being, but also being, they're responsible for managing and responding to cases of gender-based violence in their communities. So what does it mean if they're experiencing themselves vis-a-vis providing that care to GBV survivors or victims? Next slide. So, why understand the gender dimensions? As I've mentioned already, to really ensure the safety and well-being of particularly female health workers by addressing some of these structural power imbalances that heighten their vulnerability, to improve the quality of care that they provide, through providing them with support, protection, empowerment, but also to prevent workplace violence and harassment, looking at what we can use and draw on from international frameworks and policies to create safer work environments, and also to use the broader research on gender-based violence to inform and shape, human resources for health policies to better protect health workers. So as I've mentioned already, we do have a fantastic group of panelists joining us, and I'm going to briefly introduce them and then hand over. I'm sure you're all eager to hear from them. The first panelist, sadly, Lynn Marie Sardina is not able to join us today, but we do have Avni Amin, who's the unit head within the Rights and Equality Across the Life course group within the Sexual and Reproductive Health Research Department at WHO. We have Catherine Kane, who's the technical officer within the health workforce team at WHO. We also have Maren Hopfe, who's the technical officer within the health services sector at the Sectoral Policies Department at the International Labour Organization. And I'm going to be turning to each of them in turn to dive into particular issues in their respective areas of expertise, and always drawing it back to, I think, the primary healthcare workforce and issues of gendered workplace violence. So if I can hand over to Avni, and Avni in particular, it would be great, given you have close to 20 years of experience working in WHO on issues of gender-based violence in particular. And, I think a lot of the efforts and long history that has gone into positioning gender-based violence as a public health issue, what do you think we can learn from and draw on those lessons from GBV, as we look to tackle gendered workplace violence in the primary healthcare workforce?
Thank you, Johanna. It's a real pleasure to be here, and I'm going to try to capture almost 30 years of lessons learned in 5 minutes. But I think it's important that even as we focus on primary healthcare workers, and as Johanna said, many of them are women, that violence that they experience in the workplace is really a continuum of the violence they're experiencing in homes, in communities, and elsewhere. And the violence in the workplace occurs in a context, in a larger context, where violence against women is widespread and it's normalized. And so what is happening in the workplace is, in many cases, a microcosm of what is happening in their homes, in their communities. So just to say how WHO started working on this issue almost 30 years ago, soon after the Beijing Platform for Action, is violence against women at the time in 1995 was recognized as a gender equality or gender inequality problem and a human rights violation. But there was an increasing recognition that we needed to really start thinking about it as a public health problem. And the public health nature of it would allow us with tools and ability to place it on health and development agendas, and also be systematic about understanding and unpacking the nature of the problem, but also developing interventions and scaling it up. So the public health model that we took is really what people call surveillance, or magnitude and understanding the health consequences, the risk and protective factors, and then using that evidence to really think about what are the interventions that are effective, and then trying to see how we scale those up. And that's really the model that we used in the last 30 years. And so one of the first things WHO did almost 30 years ago was start with measurement and understanding across countries and across cultures how violence against women was prevalent. And the reason for this was really because, violence in many settings is normalized and it's underreported. And often what you might say is a slap, which is considered maybe normal in some cultural contexts, might be considered violence in other contexts. So it was really about getting that comparable data in a cross-cultural context. That was the starting point for our work. And now you see people often quoting the 1 in 3 figure, globally experiencing physical or sexual violence by an intimate partner, which is really the result of these 3 decades of work. And so my first sort of lesson for transferability to the work on violence against health workers is really around having a comparable set of measures to understand the phenomena of violence against health workers across cultural contexts. The second sort of public health approach is really the identification of risk and protective factors. And again, a lot of work was invested in understanding risk and protective factors. And we applied what is called the socio-ecological framework, understanding the individual risk factors, understanding interpersonal relationship risk factors, understanding community level risk factors, and then understanding broad societal level risk factors. And I'm not expecting you to read this, but really what we do now have after 3 decades of research on this is really focusing on knowing what are the risk and protective factors that we need to tackle in order to prevent violence against women. And that's, again, the second lesson here is in every context, it is important to understand those risk and protective factors in order to develop interventions that will tackle or that will mitigate the risk or enhance the protective factors. The third sort of step in the public health approach is really the importance of developing and evaluating evidence-based interventions. And in the last decade, this work has really accelerated, partly because we've had some really great funding investments in good, high quality evaluations, rigorous evaluations that have led us to identify what are some of the interventions that actually work in different settings, high income settings, low income settings. And we have packaged that evidence now in a framework called RESPECT, which each letter stands for one of 7 strategies. And I'm not going to go through those 7 strategies, except to say that each of them has varying evidence base about what is promising, what is effective, what needs more evidence, and what is ineffective. And it's as important to know what is not working as it is to know what is working. And I'm going to hone into what we've learned in the health systems space, the S of RESPECT, where WHO has spent pretty much since 2013 developing evidence-based guidelines for health sector response to violence against women. We've developed a lot of practical tools to help the health systems respond to gender-based violence, e-learnings, clinical handbooks, etc. And perhaps the important framework that has helped us advance this work in the health sector has been taking a health systems approach and using the health systems building blocks to develop interventions and make sure that it isn't just relying on health workers to respond to violence against women, but the accountability is also with the systems, with the policies, with the health managers, and others in the health system. And then finally, just moving to the last sort of step of the public health approach, it has been around implementing evidence-based interventions, and WHO is now working in 23 countries in humanitarian emergencies to make sure that our tools and our health sector response materials are being used to scale up in a humanitarian context, but also in 73 countries, we have ministries of health reporting that they're using our guidelines to guide their national health response. And this is where I'm talking about implementation at scale. One of the things, lessons learned here, is the importance of having a political mandate, and we do have one through the World Health Assembly. In 2016, we had a global plan of action on strengthening health systems response to violence against women and violence against children, which provided us with a measure of accountability. And we have indicators that we are tracking on how this health sector plan is being implemented globally. We have a database now of violence against women policies from 200 countries. And what we can see is that 38% of countries' health sector plans, national health sector plans, are addressing violence against women as a strategic priority. And 52% have clinical guidelines or health sector SOPs. And again, this is important because it helps provide an accountability for implementation at scale. So lessons learned, and this is the last slide, is that first, political mandates are key for advocacy. It is important to apply a public health approach, important to look at both health and other social economic consequences, because in many countries where there is backlash to these issues and there are sensitivities, it can provide a neutral entry point. It is important to take a health system strengthening approach, so going beyond individual behavior change and recognizing that these systems and institutions take time. I'm summarizing 30 years of work here. Important to really build solid partnerships with feminists and women's organizations, and the violence against women world has done that very, very effectively. It has been very intentional in building those partnerships. And we have really built our evidence not just from what works, but also listening to women with lived experiences. And this has really been the central point of how we have tried to center our work by applying survivor-centered principles, and the importance of practical tools and flexibility of terminology and entry points in countries. Gender-based violence, the word gender elicits a lot of reactions in many settings, and it's important to be pragmatic about which entry points you use. Thank you, and back over to you, Johanna.
Thanks so much, Avni, for presenting so much for us to sort of kick off and dive into. And I'm sure we're going to pick up on a number of these things as we come back to the broader question and answer session. We can talk a bit more. I did want to turn now to Catherine and ask you, Catherine, if you can talk us through a little bit more detail, given, there are a large number of existing international conventions, we know their instruments, treaties, resolutions, and obvious recommendations that are coming from these, spanning a whole host of different areas, whether it's humanitarian law, labor law, human rights. And, the technical guidance document, I think, that tried to consolidate all of this, the Global Health and Care Worker Compact. If you could talk us through a little bit about the compact and what it means with regards to trying to institutionalize a safe, healthy, and supportive work environment for healthcare workers.
Thank you, Johanna. And my apologies for the brief intervention. I tried to co-schedule with flying on the same day, but I felt like it was so important for us to reach you that let me just go through in 5 minutes. I'm going to stay online on the phone for the Q&A, which I'm really looking forward to. So the Global Health and Care Worker Compact, I'm starting mid-slides because I really think it's quite important to give you the picture, came out of, and it shouldn't have come out of, the COVID-19 pandemic. It should have come out years and years ago. I think anybody who's been in a healthcare environment, watched a television show, read a newspaper, knows that we are in an environment where health and care workers are not protected. And particularly the primary health care workers are not protected. And what's really interesting about this is that the WHO estimates that 90% of health interventions that people need throughout their lives can be provided indeed through primary health care. So why aren't we protecting the people who are doing this? So member states said to us in 2021, please find a technical document, assemble all of the relevant international laws, treaties, standards, and guidance, and tell us what we should do to ensure that we have a health and care workforce. That birthed the Global Health and Care Worker Compact, which came in front of the World Health Assembly in World Health Assembly Resolution 75.17. It has 4 domains and 10 areas of focus. First domain, preventing harm from occupational hazards, violence and harassment, and during situations of fragility, conflict, and violence. Next slide, providing support. What we're looking at with regard to providing support on the next slide is ensuring that we are providing the right resources, fair and equitable compensation, social protection. So, and as well, we're looking at providing physical and mental health resources so that people are enabled to do the jobs that they need to be doing. This is because 67%, and by the way, please feel free to reach out on statistics and data because we want to make sure this is right. 67% of health and care workers globally are women. They earn on average 24% less than their peers who are men. In the same point, they also hold only 20 to 25% of leadership jobs. So when we look at the third element, ensuring inclusivity, we're also ensuring equal treatment and non-discrimination opportunity for all. And the final element that we're looking at is safeguarding rights, which is ensuring your right to freedom of association and whistleblower protection. This is a compilation of over 190 different international laws, treaties, and resources. So what are we doing about this? How is this actually going to come into practice? We have done a desk review of over 160 countries to see where they are performing in terms of the 4 domains and the 10 areas of focus. And we're finding that no country is doing this well. We need to do better. We need to do better together. The information is being presented on the new Health and Care Policy Lab, which is a portal supported by the O'Neill International Health Institute of Law. And you'll see in a subsequent slide that we highlight this portal. What can you do? So the next question is, what's your role in this? We need more information. We need people to be doing research into these areas, whether it's all 4 of them for your national context, whether it's a single domain or a single area of focus that you're interested in, protection from violence and harassment, whether this is gathering with your Ministry of Health and other stakeholders to advocate for the rights that health and care workers need. there is a role for everybody to be doing research, to be advocating, to be contributing evidence, and to support countries in strengthening their laws and regulations and ensuring that all of your health and care workers can concentrate on providing exactly what Avni pointed to, which is sensitive quality care for the people who absolutely need it, particularly those in the furthest flung context. I'll just add, let's stop using frontline. Health and care workers are not soldiers, never should be confused as such. I think we have some recent examples of where they are, and we need to start saying at the forefront of care, because that's what they do. So please, please, please reach out to us. You'll see on this publications page and on a number of the QR codes throughout my presentation, which will be circulated later, that we have a number of pieces of data that we'd like to share. We'd like to engage you in future research. We'd like to engage you in future advocacy and government efforts. And we really encourage your questions. But why health and care workers? Because we cannot do the jobs that we need to do without them. I'll turn it back over to Johanna, but I'm really looking forward to the Q&A for as long as I can stay on the line. Thank you.
Thank you so much, Catherine. We really appreciate you fitting us in despite your travel. So thank you, and thank you for that presentation. I'm going to turn now to Maren, and Maren in particular, I wondered if you could talk us through the ILO Convention 190, C190, which was adopted in June 2019, and really is the first international treaty to recognize the right of everyone to a world free and work free from violence and harassment, which includes gender-based violence and harassment. And I think it's, at least over the past decade, one of the fastest ratified conventions, if I'm not wrong. So Maren, could you tell us a little bit more, about C190, but in particular, what does this mean as we look to ensure safer workplaces for healthcare workers at the forefront of care, as we've heard from Catherine?
Thank you. Thank you very much, Johanna. Hello, everyone. It's a pleasure to be here with you today. Let me maybe start by explaining a little bit more what does it mean to have a convention, and what are international labor standards, and what does this all have to do with realities of the health sector. So as you all might know, the ILO is a standard-setting organization. That means that it develops international labor standards. And these international labor standards are actually legal instruments which are developed, discussed, and drawn up by the ILO's constituents. And the specialty about the ILO is that it's not only our constituents and not only the governments, but we have the same voice and participation of employers and workers. So our international labor standards are actually consensus between these three governments, employers, and workers on what are the main standards and rights that workers should enjoy in the world of work. And they are setting out basic principles and rights at work. And these international labor standards can actually take different forms. So they can take the form of a convention or protocol, which are actually legally binding international treaties that may be ratified by member states. But they can also be recommendations, which are non-binding guidelines. And in many instances, for example, also for the Convention C190, conventions lay down the basic principles to be implemented by ratifying countries, while then the related recommendation sort of supplements the convention by providing more detailed guidelines on how it can be applied. Once a convention is ratified by a member state, that means that the provisions of the convention need to be applied in law and practice of that country. And there is an ILO supervisory mechanism that actually then the countries also have to report to on how they are doing in terms of adhering to the provisions of the conventions that the country ratified. Now, let me turn to the Violence and Harassment Convention, which is one of our newest conventions. It is the first international standard on violence and harassment in the world of work. And as I said, it's a binding international treaty. And it sets out everyone's right to a world of work free from violence and harassment, and it includes gender-based violence and harassment. It has an accompanying recommendation number 206, which actually provides that members should adopt appropriate measures for sectors or occupations in which exposure to violence and harassment may be more likely, and it specifically mentions the health sector. So it recognizes that workers and occupations and the health sector is a sector where workers are experiencing a higher risk to violence and harassment, and where there need to be specific attention to that. Now, it defines violence and harassment understands it as a range of unacceptable behaviors and practices or threats thereof, whether it's a single occurrence or repeated, that aim at, result in, or are likely to result in physical, psychological, sexual, or economic harm. And it includes gender-based violence and harassment, which means that it is directed at persons because of their sex or gender, or affecting persons of a particularly sex or gender disproportionately. So you see, it covers a broad range, but also the question is, this convention, who does it cover? It basically ensures protection to all workers, irrespective of their contractual status, both in formal and informal economy. And I think that's very particular. It's very important also for the health sector, as we know that in many countries, a lot of health workers are actually providing care in informal employment. It also applies to workers in private or public sector. So it covers both. But more than that, it covers other persons in the world of work. So it broadens the scope and also covers persons in training, including interns and apprentices. It covers job seekers, it covers volunteers, it covers people whose contracts have been terminated, but also individuals exercising the authority, duties, and responsibilities of an employer. So you see, it has a very broad scope that covers everyone, and I think this also, especially volunteers, etc., is very important also for the health sector, as we do have a lot of community health volunteers and other health workers providing care at the front line who are not in formal employment. The convention actually sort of takes an inclusive and integrated and gender responsive approach to not only ensure protection from violence and harassment, but also to prevent violence and harassment in the world of work. And it's rooted in sort of three main pillars. The first being prevention and protection. So it calls upon members to adopt laws and regulations that define and also prohibit violence and harassment. And we know that there are some countries, for example, China, that have laws in place that specifically target violence against health workers. But it also says that there should be laws and regulations that require employers to take appropriate steps to prevent violence and harassment, which can be in the form of adoption and implementation of a workplace policy, always in consultation with workers and their representatives. It also includes the call for identification of hazards and the assessment of the risks to be able to have control measures. And also to provide workers with information and training to actually be able to identify the hazards, to identify the risks, and then to jointly come up with measures to prevent and protect workers in their workplace realities from violence and harassment. The second one is enforcement and remedies. So that includes that there also need to be measures to monitor the implementation of the convention or of the measures to prevent and protect from violence and harassment, ensure access to appropriate and effective remedies, but also that there is safe and fair reporting mechanisms, because I also think that especially in the health sector, what we see a lot is that it's been perceived that it's part of the job, right? So you deal with people in distress, you say, the person didn't mean it that way. Yes, but violence and harassment should never be part of the job, and it should always also be reported, and therefore there need to be safe and effective reporting mechanisms. but it also needs to make sure that there are not only reporting mechanisms, but also that there are supportive systems and services in place afterwards. There are two specific provisions there, and I would like to mention here is that it says that the convention says that members should provide that victims of gender-based violence and harassment have effective access to gender-responsive, safe, and effective complaint and dispute resolution mechanisms to support to services and remedies. And I think another aspect that is very important here is that it needs to be ensured that workers have the right to remove themselves from a work situation where they have reasonable justification to believe that it presents an imminent and serious danger to life, to health, or to safety due to violence and harassment. And that needs to be, this right should be granted without suffering of retaliation or other undue consequences. And there is a duty to inform the management and the employers. But I think this is a very, very important right also in terms of the health sector, where health workers are often challenged with the decision of providing care while putting themselves into danger. So there is always this balance. So workers have the right to remove themselves from situations that they believe have an imminent harm to them. Then the third pillar is training, guidance, and awareness. So where employers and workers and their organizations, as well as relevant authorities, should provide guidance, resources, trainings, awareness raising, etc., to sort of, make the awareness on the problem itself, but also to jointly discuss how there can be preventive measures and protection measures, but also how can there be support services in case a health worker experienced violence and harassment. So to summarize, the Convention 190 actually provides a framework to prevent workplace violence and harassment, including gender-based violence and harassment, through a clear definition, but also through effective implementation strategies. And it also calls for policies and measures to be developed in dialogue, through dialogue with governments, with employers, with workers, to ensure that the procedures and policies that are put in place are actually reflect the needs and realities of the workplaces, in this case, the health workplaces, and that respects the rights and conditions of health workers as well. So I stop here, and I'm very much looking forward to the question and answer session. Thank you very much. Back to you.
Thank you so much, Maren. And I think you have, through your discussion or presentation to us, have actually addressed some of the questions that came in prior to the webinar kicking off around, are informal healthcare workers covered? What about the private sector? You've mentioned volunteers and trainees as well. And I think if I can, I'm very conscious of time, and I would like to engage a little bit with everyone joining us today. So please do drop your questions in the chat. We have one question that has come through from Dr. Galila Assam, who was asking from Yemen, who is asking, and perhaps I can frame this question a bit more broadly, but if we think about, particular humanitarian crises, conflict, whether it be in this case Yemen, but if we look at what's happening in Gaza, Sudan, again, the exposure of healthcare workers to violence is tremendous and in many ways amplified in these contexts. And what does this mean vis-a-vis particular policies or frameworks that can be used and extra provisions put in place to really ensure their safety, again, from a gendered lens, but I think more broadly as well. So, Catherine, I don't know if you're still with us, and I don't know if you want to jump in, because I know you're very tight on time, and then I can maybe do a quick round. Catherine, are you still there?
Yes, and hopefully we won't have, I'm so sorry, we may have another boarding announcement. So what can we do? These international laws, treaties, and policies apply to all contexts at all times, and they are, in fact, if you look at the conflict and violence, they're based in the Geneva conventions and its additional protocols, particularly for this area, although there are other legal references. The CARE Compact itself is non-binding. However, it is an instrument that's been designed by, requested by, and approved by countries around the world. So using the wheel of interventions is something that we would like and something that you can do in a variety of contexts within your broader advocacy and policy objectives. What can we do? I think all of us feel a bit overwhelmed at this point, seeing the violence that continues even in the face of the overwhelming support that we saw during the global pandemic. So what I would suggest is that we need to do not only work now when we are in less of a global and more of a regional and country situation, and continuing to ensure that we look at these protections and that we reinforce our own country's commitment to ensuring that they are, in fact, realized.
Thanks, Catherine. Avni, do you want to come in from the point of view perhaps of GBV more broadly, but yeah.
Yeah, I mean, I think as Catherine said, the situations in Yemen and Gaza are overwhelming. I mean, apart from the fact that we do have these normative frameworks in place, but they are being ignored, and that's just a sad reality. One of the things I think we have learned, and so we are working actually in Yemen as well as in OPT to integrate GBV in the health cluster response. And obviously the health workers are part of the trainings that we offer to respond to sexual violence in conflicts, but in general, provide empathetic care to patients. And one of the things we've learned from our humanitarian work is really the importance of integrating this into emergency preparedness and response. You know, in the midst of a conflict or in the midst of a crisis, it's really hard to rally around and then try to put these mechanisms in place. So I think and again, the COVID pandemic was another one where you learn that you actually have to be prepared, and pandemic preparedness has to address and integrate violence prevention and response into the planning itself. We do a lot of work around survivor-centered care and first-line support to survivors of gender-based violence. What we found is in our work with health workers, when we train them to do this, it often also helps them. We do a lot of stress management and vicarious trauma response as part of the mental health support. And so it is that health workers can effectively address gender-based violence when their own issues of violence in their own personal and professional lives are also recognized and addressed. So we do have a lot of, we have sessions on, how to do self-care for health workers who are on the front lines. And I'm happy to connect the person from Yemen to our country office who's involved in this work. Over.
Thanks so much, Avni. Maren, do you want to come in?
Yes, thank you very much. No, it's a super interesting question. And I think as Catherine and Avni already mentioned, that, although we have international norms and laws and regulations and standards, the reality in those situations is often completely different. And we need to be in also in discussion. We need to listen also to those health workers who are in the situation, to see what are the actual needs, and as Avni also say, to have training, to raise awareness, to support the best we can. Now, there is, I think, one sort of or some question, or not question, but the statement that I heard quite a lot during the COVID pandemic, which also raised a bit of concerns from my side, is that I sometimes heard that, health workers know how to protect themselves, and health workers, know best how to make sure that they stay safe, and they know all about their health. And even if even if most of them probably do, they still need support, right? It's not that they can operate. They know that they should how to protect themselves, but if there is no protective equipment, that doesn't help. So I think we need to also break a bit the stereotype that that the health sector doesn't need help, or doesn't need support, or doesn't need to have mechanisms in place that supports health workers to provide quality care. Because I think there was also the WHO a couple of years ago had this on the Patient Safety Day, raised awareness on the fact that if health workers are not safe, they're not in a position to provide good quality care, and patient safety is at risk. So I think we need to have much more discussions on that, also in the conflict situations, which I know is a very challenging situation. But there are a lot of things that also can be done, little things that can be done to support health workers, to enable them to provide good quality care. But I think therefore we also need to listen, we need to be in contact, and we need to then address the needs that are expressed, just as Afni and Catherine said. Thank you.
Thanks, Maren. I think we have time probably for one more quick question, and if I can ask, it's from a nurse practitioner who in particular has asked, given a lot of the cycles of violence are less tangible, right? And it is cycles of violence often, that are reinforced by particular structures. Where to even begin, perhaps in a very practical way, to intervene and leverage some of these policies or frameworks that exist. And I don't know if you would be able to provide, an example or could speak to this in a very practical way. And I thought it's important for us to ground it in that reality. So, Maren, maybe I start with you and or Catherine, are you dashing?
Yes. Nurses, 59% of the global health workforce. Thank you very much. Thank you to our nurse practitioner. As a very, very concrete practical tool, we will be releasing quite soon, both on our website and on the Health and Care Worker Policy Lab, a self-assessment tool. There's a long form and a short form that have specific guidance and resources. And thank you to Maren, by the way, for her contributions from the ILO perspective. So the Policy Lab at present already contains a number of resources that can be leveraged by individuals within their health facility environment or within their health practice environment, because as we know, not all health exists in facilities. So these resources not only are the international legal frameworks, but they also include the national legal frameworks, and they include specific resources like the Caring for Carers Occupational Health and Safety Guide that was co-produced by ILO and WHO. So what we would encourage is to visit the Policy Lab and to visit the Care Compact page itself, where there are some very concrete guidebooks on practices and policies that one can make at any level.
Thanks, Catherine. Maren?
Yes, thank you very much. And thank you, Catherine, for also alluding to a lot of the work that ILO and WHO are doing together in this area of work. Just to add to what Catherine said is that, first of all, there is a normative standard as well. We do have a nursing personnel convention. It's one of the very few occupation-specific conventions that the ILO has. It is from 1970s. It has around 40 ratifications. So to compare the Violence and Harassment Convention, which was adopted in 2019, already has 44 ratifications. So I think in terms of the legal standard, there is something for nurses out there that could be much more much more promoted to ensure that there is also legally binding protection for nurses in countries. In the more practical way, the ILO and WHO have the HealthWise tool. HealthWise is a practical participatory quality improvement tool for health facilities. So it looks at improving the work environment in general. It does cover aspects of occupational safety and health and other aspects. It is based on 8 modules. And one of the modules is actually looking into violence and harassment and prevention and protection from violence and harassment in the workplace. So what we're supporting together with WHO, among others, through the ILO, OECD, WHO Working for Health program is training on the HealthWise approach. In health facilities, for example, we implemented the approach in Pakistan in 3 hospitals with quite interesting results. For example, one based on the assessment, based on the occupational safety and health, or the committee that was established in the health facilities to assess what are the risks, the challenges, where is room for improvement, was the implementation of a reporting mechanism for reporting violence and harassment. And health workers in that health facility were saying that it's the first time that they realize that it's not part of the job and it needs to be reported, and they are allowed to raise awareness about it. So that was interesting. I'm happy to share some links to the work in Pakistan, but also to the HealthWise tool. So that are, some of the trainings in very concrete terms that WHO and ILO are doing together, and that might be of interest as well for others to explore further. Thank you.
Thanks, Maren. Avni?
I've just posted a lot of practical tips in the chat, but just to say, I think the violence against women health sector response has largely been led by the innovations and activism of nurses, and we are part of a nursing network on violence against women, where a lot of the job aids, a lot of the evidence, a lot of the learnings have actually been shaped by nurses in this field. One of the most practical things that we offer to train health workers is called Lives, which is a job aid to help operationalize WHO's recommendation on offering all survivors who disclose violence first-line support. And Lives is really 5 steps. Listen to the survivor with empathy. Inquire what is their needs and concerns first. Validate so that they are not feeling blamed or judged. Enhance their safety. So there are tips around safety assessments and planning. And facilitate social support relying on their own informal networks and also formal networks where they exist. And what we learned is that this simple sort of job aid, and there's a lot behind this job aid, not just these 5 steps, but it's an easy mnemonic to remember, is it can be practiced with anyone who's subjected to violence, and anyone can be trained to respond to violence using Lives. In our Caring for Women Subjected to Violence training curriculum for health workers, we also have a self-care module for health workers to manage vicarious trauma, in which there's a lot of emphasis, which we have developed in collaboration with the mental health department, on stress reduction and stress management, partly because we know that this is one of the most biggest manifestations of or consequences of violence, and I think health workers themselves, who are both subjected to violence but are also day in, day out listening to stories of violence, can actually practice some of those techniques in a very practical way. So, over.
Thanks so much, Avni. We're now bang on the hour. I know we started a bit late, so I wonder if I can grab 5 minutes of your time just to share, if you had one final thought or reflection that you'd want to leave us all with, what would that be? And maybe I can quickly I'm always conscious, Catherine, that you're going to dash off at any point. Do you want to kick us off and then maybe she's had to go. Okay, so maybe Maren, I could turn to you and then end with Avni.
Yes, no, thank you very much. Maybe just so two quick thoughts. I think one is that we need to remember that health workers are workers, and as such, they do enjoy rights, and they have rights, which are enshrined in international labor standards and other international legally binding documents. But then a second point that I would like to emphasize again is that our experience shows that we can only advance on this together. So collaboration between governments, between workers, between employers, their representatives, other stakeholders, associations is key. We need to listen to everyone. We need to make sure that everyone has a voice, is heard, and only together we can advance and make sure that we have a future health system that is able to protect and prevent health workers from violence and harassment. Thank you.
Thanks, Maren. Avni?
Really listen to survivors, listen to survivors' voices and what they have to say in guiding your intervention, and that applies equally to health workers. Listen to the health workers and what they're saying and developing the interventions. And I think the second thing for me has been be systematic. It does. I think you don't need to reinvent the wheel for this. We've got 30 years of experience and 30 years of lessons learned. So hopefully you can just transfer some of that to the addressing violence against health workers without needing 30 years to do this.
Thanks so much, Avni. And I think that's a really important point. And I mean, as I'm sure everyone can see with regards to the resources that were shared as part of the webinar today, but what's available more broadly, there's a lot already out there that we can draw on and use. And it's about sharing that information more broadly. I won't try to wrap up and summarize everything or leave with a pithy statement, unfortunately, but I think there was one comment that came in, and this ties sort of as we look forward to the second webinar of this series. It's from Mokete Kobotle, who's an independent researcher from Lesotho, who was really raising the need for more evidence-based research to really better understand, the drivers behind gender-based violence, particularly in the health workforce, but what can be done to nudge people out of that behavior, if you like, was some of the terms used. But I think this brings me to the next webinar, which will happen later on in the year, but is focusing on research to better understand patterns of violence in the primary healthcare workforce. And we'll be doing it with colleagues, as I've mentioned, in my initial presentation from the School of Public Health, from IFACARA, and also the Institut National de Santé Publique in Burkina Faso. So do look out for that webinar. Information will follow a bit later in the year. And thank you so much, everyone, for joining us today. And thank you again to the fantastic panelists and the IIGH team who've worked very hard to host this webinar. Thank you.
Thank you, UNU, and thank you, Johanna, and to my co-panelists. It's a fabulous learning for me as well.
Thank you very much also from my side for the great discussion and the great organization and facilitation. Looking forward for more collaboration.
Yes, I hope so. Thank you very much, everyone.